here, ActinMyosin, little review. Remember, actin and myosin converts a chemical energy into mechanical energy. It's like that uses ATP and phosphate. Phosphate sort of helps pull it back, gets the muscle ready, and then the actin and myosin join up through calcium. That all sound familiar to you? I mean, calcium pushes the troponin out of the way, then the myosin head binds to the calcium, and so it cocks it back and it gets it ready to contract, right? So it takes chemical energy to mechanical energy. And this is just a sort of a protein cloud. That's what's sort of mind-blowing about it. Just a cloud where these things change shapes and they're able to bond with it, okay? And we use the term, and we use this again today as a rowboat, right? We talked about that, where if you have a boat and you have one row and you're doing this, it takes a lot more work, right? And there's a lot less movement. Where if you have 3 or 4 people in a rowboat and you're rowing, then it takes you get a better push out of it, a better row of the boat, or better movement of the boat. Same way with the muscle. If you have more myosin heads that are activated, that are combined with the actin, you get a better contraction, right? Makes sense? Okay. So that's what this says here. When we, like right now, and just after spring break, you have low energy, really low energy, okay? Everybody does, including me. So you're sitting there, and it's low energy. This is a neuron cell, and this S is for sympathetic stimulation, sympathetic input, right? So the sympathetic nervous system is going to influence, and these little things here are receptors, okay? And then in between here is where the chemical mediator is, like epinephrine, chemical, what am I thinking of? Neurotransmitter is, okay? And so what happens is, in a low state, a low sympathetic response is a low amount of calcium. So if we have a low amount of calcium, we're not going to engage all the myosin heads, right? And so because you don't need it. You don't need the extra energy. If you had the extra energy, then you'd be you'd want to get up and walk around and everything, right? So it's low energy. The body doesn't need it. These discs, these Z discs, there's Z disc and M disc, and they just pull with the muscle group. It's not really anything to remember. It's just that these discs help pull these. These are the myosin heads up here. So it helps in contraction. So really, only about 20%. We're not using a lot of energy, okay, right now. The next thing is when the person starts walking. So they're walking, so they're going to use more energy, obviously, right? So more sympathetic response, more calcium. The sympathetic response causes the calcium to come out more, okay? Where's the calcium come from?
The sarcoplasmic reticulum.
Very good. The SR, how do you say that again?
Sarcoplasmic reticulum.
Good. Comes from there. So the more sympathetic response, the more release of calcium, and then the more myosin heads that, the more troponin that's pushed out of the way, and the more that it combines with the actin, and the more myosin heads that can be engaged. So it has the number 60% there. So this ventricular cell is going to contract more because you need more energy. It's the response to the body, right? And then the other one is running. So the same process. The more this person is running, the more sympathetic response, the more calcium, the more myosin heads that are engaged. That is an important concept to understand as we move forward. It's just like if you think of the rowboat, I think that's the best example to sort of mentally picture this in. When the heart's contracting, okay, that left ventricle contracts. We want to engage the proper amount of actin and myosin heads, correct? To get the proper contraction. Without the proper contraction, then we get into problems where we have the decrease in cardiac output and everything, right? Everybody good with that?
Mm-hmm.
Not too much there. That's really common sense, okay? The next topic, this cardiac conduction, we're doing all this in except the fact that you have different cells here. So, anybody remember what 3 types of cells the heart has? But-
Pacemaker, then there's
Contractile.
Yeah.
what's the other one's like pacemaker. That's all I remember. The other one's like pacemaker.
Starts with the C. Hmm? No, that's what she said. Contractile cells. Conducting.
Yeah.
Oh, okay. Conducting cells. So you have pacemaker cells. Pacemaker cells are in the SA node, the AV node, and there's pacemaker cells in the ventricles, right? Because the intrinsic rates. What's the intrinsic rate of the SA node? Very good, 60 to 100. So it's going to depolarize 60 to 100 times per minute normally. What's the intrinsic rate of the AV node?
40 to 60.
40 to 60, right? And remember, these are ranges, okay, in the ventricles. Intrinsic rate of the ventricle.
Oh, hold on, I'm sorry.
40 to 60 is the AV node, then has to be less than what?
Is it like 20 to 40 or something?
Yeah, it's less than 40.
Oh.
We said it.
Yeah. Huh?
That's what we said.
Why can't you do it?
It's okay.
You can tell me again. Okay.
Don't beat up
So,
on the old man.
Anyway, so you have pacemaker cells, then you have conducting cells, and then contracting cells. Okay? They literally touch each other, and they lay over each other as they conduct. Now, this big thick line through here is where these cells, these contracting cells, sort of, it's like a wall. It is a wall. It's a septal wall where there's not able to conduct through that wall. Okay, so the conducting fibers have to run down the track. Okay, the electrical track. So they run down how he has it drawn here. This big white line. It runs down this line because if these atrial cells, they're all myocytes, right?
Mm-hmm.
I mean, they're the same. But if these cells touch these cells, then they would all contract together. Okay? So there has to be sort of a insulation in between that so they don't contract together. Does that make sense?
Mm-hmm.
Yeah, otherwise they're all touching each other. They would contract all together. Now this strange word here,
City.
huh?
That's spelled wrong. City.
I didn't spell it. But anyhow, this means that as far as the heart is concerned, it's one big, the electrical part of the heart, it's one big cytoplasm, or it's one big cell. Because this means that they all contract together. Okay? So as these cells contract, the electrical wave moves across the cell. I had this cool video I'll show you later. I actually got it off Facebook, but you can sort of see the natural function, the contraction, and you can see the wave of contraction going through it. Okay, it's pretty neat because once they all contract sort of together, and it's such a small amount of time that you don't really see it. You know, it's like one contracts and another one contracts like this. They all sort of contract together, but it is a wave of contraction. Okay? And this is what that means. That syncytium, or whatever how it's pronounced. Wish I knew who made that word up. But it means that it's one big cell. So the heart itself, so as it looks down through this left ventricle, okay, it sees one cell, not a gazillion cells. Okay? The same way with the atrium. It sees one atrial cell, not a gazillion of them. Does that make sense to everybody? Okay? So the other things is that we'll cover in the EKG portion of it, but on the conduction, the times and PR interval, we're doing that with EKG, right? So we'll skip over that. Does that make sense to everybody? Everybody good with that part?
Mm-hmm.
All right. Just remember the three types of cardiac cells, and then this part here, how it spreads through one cell. And then we went through action potentials and everything with Karina's class. This is a nerve cell. See, this would be the electrotonic potential, right?
Mm-hmm.
And then this would be an action potential. 2 and 3, phase 2 and 3 are only in cardiac cells. This slow release, influx of calcium and sort of the closing of those slow calcium channels. This slope here is only in a cardiac cell. That's important because of the fact that we don't want this in a cardiac cell. We don't want that electrotonic potential in a cardiac cell because it would contract very quick and it wouldn't make it up the ventricle in time. Remember, the heart, that signal has to travel up the ventricle. And as we get further into this, that'll make a little bit more sense when we get into some problems with contraction and MIs and stuff, okay? They call it a wall abnormality. I have to say that word slow. Wall abnormality, if there's a blockage here, okay? Because the electrical impulse has to go around it. Can't go through it, it's dead tissue. You know, it won't go through. So it has to go around that. And that takes time. That's an important key to remember, time as an electrical pathway. It takes, even though it's very fast, it still takes time. Alright? So remember the phases. Phase 0, this fast sodium influx. So we still here, we have this resting potential. So this is, there's nothing taking place here. Okay? And then we have this sodium influx. Something causes that to, the excitability of that cell causes that to, that sodium. So you have this to start moving. So you have this rapid sodium influx in phase 0. Why they would start at 0, I don't know, but someone smarter than me came up with this. Okay, so phase 0, then phase 1 here is this fast calcium exflux, or when the potassium exflux. So the potassium is leaving the cell, so the sodium enters the cell, the potassium leaves the cell. Then you have 2, 3 that's only found in a cardiac cell. So you have a slow influx of calcium to make that contraction longer. Okay, so we need that length of contraction. Then we have it phase 3 where it actually closes. Then it comes back down to a resting phase. It says here 350 milliseconds. So I mean it's very, very quick. Okay, 350 milliseconds is like 0.35 seconds. So I mean it's right. It sounds better, 350. We can do that. I mean, you guys know milli, right? Milli, 3 significant figures. So you have 1, 2, 3, so 350, right? Okay. Just want to make sure we were good. You're in a desperate situation if I know more math, that math, and you don't. Okay. So, everybody good with that? Action potentials. I think we've covered that pretty much in the last few days. And then again here, just this sort of input, the same thing here. And then as the cell, remember it's an action potential, so the row your boat thing, right? You have this, influx, exflux, influx, exflux, influx, exflux, and it's just a wave and a pattern. It happens all the time. Okay, because you don't ever want your heart to stop contracting, correct?
Mm-hmm.
Yeah, that would be a problem. The EKG stuff, we're beating that dead horse already. So with EKG recognition, remember everything in lead 2 makes it pretty. It's upright. The QRS complex is upright, and then lead 1, because it's just measuring electricity. So we go from that's lead 3, from positive to negative. Everything goes to ground, so positive to negative, correct?
Mm-hmm.
So it comes up here in this direction. So it's looking electrically at this direction here, from the left leg to the right arm. It's looking at that. Lead 1 looks from the left arm over to the right arm. Right. And then lead 3 looks from left arm to left leg. It looks downward like that. What this is going to do is just mess with the QRS complex somewhat. So you have to know what lead in recognition, EKG recognition, you have to know what lead you are. The default is always lead 2, right? Because in lead 1 and 3, it inverts the QRS complex. It's okay. There's nothing wrong with that. You just have to keep that in mind if you're doing the recognition part of it. And we're going to talk about this in just a minute when we talk about the outputs. But we have to know the bradycardias and tachycardia. So if the patient has a fast heart rate or a slow heart rate, we need to figure that out, right? We need to really recognize it and figure it out and say, okay, these are the reasons why. Why does this patient have a fast heart rate, tachycardia? Why do they have a slow heart rate? Either way, it's going to cause a change in cardiac output, correct? If it's too much, if it's too fast, it's going to affect cardiac output. If it's too slow, it's going to affect cardiac output. So we need to know why. Let me flip. Yeah. Because we'll talk about all this in a minute. Let me stick with the slides here for a second. So a bradycardia is going to be either an increase in parasympathetic response. Remember, the parasympathetic nervous system will slow everything down, okay? The sympathetic speeds the heart up. Sympathetic speeds the heart up, parasympathetic slows it down. So we could have, for a bradycardia, we could have something happening where the SA node is slowed down. Next period, we're going to talk about junctional rhythms, where it's absent. There's no SA node impulse. Okay, the SA node has been knocked out somehow, damaged. Okay, so either there's going to be an increase in parasympathetic response, there might be a block somewhere in the electrical pathway, which is going to slow the heart rate down. We skipped over heart blocks because we don't do them last, but with the exception of probably a first-degree heart blocks, the other heart blocks are slow. They're slow because of it takes more time for the electrical signal to get to the ventricle, okay? It's the easy way to remember that. So something's taking place there with the bradycardia. So we just have to figure out why, and then we do have to speed the heart rate up, correct? So in the emergent care, then we want to speed the heart rate up to increase cardiac output, and then give us some time to figure out why is this so slow, right? Sometimes the patient may have to go into the cath lab and get a pacemaker implanted to pace the heart, to speed it up. Okay? Both slow and fast. Then you have a tachycardia, which is sort of the same. It increases the pace. These pacemaker cells have an increase in depolarization. So the maybe it's a greater sympathetic response. Okay, so we don't really know. It's things that we have to investigate. Why they have this tachycardia? Why they have this bradycardia? So when you're doing your patient assessment, if they have a tachycardia, then you have to start thinking, well, why do they have that? Okay? Or they have a real slow bradycardia. Why do they have this bradycardia? That's something that you have to sort of put back into your mind and start working through that. With the decrease in cardiac output, you should expect what with the blood pressure?
Can you repeat that?
With the decrease in cardiac output, you should expect what as far as pressure?
A decrease in blood pressure.
Yeah, decrease. So if you have a real bad, slow bradycardia, then you can expect a low blood pressure. Okay, so now you have two problems, correct? So now you have to, if you correct the bradycardia, then you're going to correct the output, right? Potentially. So we'll work on that. That's something that we'll work through, sort of problem solving. Then you have a re-entry tachycardia. We talked about AFib, right? Right, yeah. And WPW, we talked about those a little bit. Then a paroxysmal tachycardia, or an SVT. So those are re-entry problems. VTAC we haven't got to yet, but it's a re-entry problem. VTAC is potentially life-threatening. Okay, that's something that you're going to have to fix right away because it's like 300 times a minute or plus. So their output is going to drop quite a bit. And then we have this cardiac cycle that we go through. Big thing in this cardiac cycle, you already know, cardiac output, stroke volume, and heart rate. We're going to break that down a little bit more in a minute and say, okay, this is what stroke volume is. This is how you measure stroke volume. We know how we measure heart rate, right? But each one of these, just like the EKG, this is a waveform. And so once you get it, depending on what kind of medicine that you go into, you will interpret different waveforms. So you're learning the EKG waveform. What other waveform do you know about now? Like a waveform is this. This here is a waveform.
Oh, no, that one. Then you know the potential.
No, don't overthink it. It's easy. No, this is part of this. The SpO2, the pleth. It's called a pleth. When you put the SpO2 on, it creates a waveform over here in the monitor, right? You've seen it before. It sort of comes up and like this, right? That's called a pleth, Pleth, and it looks a certain way. And if it's all crunched down and outside of the normal way that it's supposed to, you can't use that SpO2 reading. The pleth is messed up. The number that you get is going to be messed up too. Okay? A lot of patients, it won't register the percent, like we're looking, for that, 95+%, right? It won't register that, but they look up at the waveform and the waveform is good, then they say, okay, everything's good. The waveform is good. Otherwise, the waveform would look different. Just like end-tidal CO2, we haven't really talked too much about that, but it's a waveform. We talked about in asthma, we talked about that, what was it? Sharp tooth. Sharp tooth, right? That sharp tooth is a waveform. Well, it's not normally supposed to look like that. It's supposed to look sort of like a little rectangle. Right? So you look at that waveform and say, oh, that's a bronchospasm, right? So not much there. We're not going to do too much with the cardiac cycle. Stroke volume, cardiac output equals stroke volume times heart rate. Ejection fraction, we get into this, 55, 60%. You know, I think when we talk about CHF, we talk about 55%. Right? So that's good. Normal cardiac output is 4 to 8 liters per minute. And cardiac output always equates to what? Yeah, but what are you getting out? Blood? Yes, that's right, blood. But what's the important part about the blood? Oxygen. Always oxygen, right? Especially when we go into what we're about to go into when we talk about anaerobic metabolisms and different things, right? Oxygen. Decrease in cardiac output means a decrease in what? Oxygen. Oxygen to the tissues. That's the important part to remember. Okay? Yeah, it's going to affect the blood pressure late, but it affects the oxygen delivery quickly. Okay? That's where you have someone with a low cardiac output, so you can expect what in their mental status? Yeah, potential altered mental status. Good. See how those connect together? So you're not thinking, oh, they must have less than 4 liters per minute, cardiac output. If that's going through your mind, you're overthinking it. They're altered because they may not be getting enough oxygen. Okay? That's thinking directly to it. We need the physiology every once in a while, but be careful not to overthink it. All right, good. Okay. So determinants of cardiac output. This is how we're going to determine the cardiac output. Yes, stroke volume times heart rate. Okay, but stroke volume is equal to ventricular volume. Okay, so when we look at the formula for what we need for stroke volume is ventricular volume minus residual volume. Okay, so if we have a problem with stroke volume, we don't have enough stroke volume, so we have a problem there. We can increase ventricular volume, right? Mm-hmm. Because that's mathematically that works anyway, correct? So if we want to increase stroke volume, we can increase ventricular volume. If we want to increase stroke volume, we can decrease residual volume. Okay? This residual volume is also in systolic. Well, this residual volume, if you're right, this residual volume is in diastolic volume.
Oh, okay.
Yeah, so the volume at the end of diastole, that's the residual volume. That's the volume of blood left in the ventricle. Okay? Now, how do we increase? Because maybe the goal is to increase stroke volume. How do we increase the ventricular volume?
Wouldn't you reduce the contractility?
Well, think real simple.
You just need more blood.
We want to increase ventricle volume. So what is this first?
How much? Yeah.
That's right. How much blood's in the ventricle? Where does it go first? Atrium. So we have to increase what? Yeah, we have to increase the blood coming back from the atrium to the atrium. to increase blood coming back to the ventricle. Okay, so now what do we have to do?
Increase blood coming in from like the system.
Yeah, exactly. Yeah, we have to increase blood flow back to the heart. So in the vena cavas and everything, right? We have to increase that blood flow. That's called preload. Okay, so we want to increase preload. There's a lot of definitions of preload, but I like to think sort of in a simple term. This is the blood coming back. This is the preload. It's loading up, preloading for contraction. Okay, so if we think about preload, it's the amount of blood that is returning to the heart, right? So we want to increase this preload. We have to increase preload to increase ventricular volume. It's been a while, but we remember we have preload and afterload. We'll talk about afterload in a bit, but preload is just the amount of blood returning back. It is different technically. I get it out. Technically, but you have what's a term called venous return. Okay, venous return is the amount of venous blood coming back to the heart. Okay, so it's almost the same. It's just not quite the same. Okay, but that's for right now. It doesn't matter. Okay, so we want to increase preload, or we want to increase venous return. Okay, to increase ventricular volume. That makes sense, right? All right. So we do that, and we do that by this equation. Don't worry, we're not getting into the math here, okay? But we get into. I just want you to know this guy's name, really. Darcy's equation.
Oh, Darcy's. You spelled that wrong.
Yeah, I know. It's flow, pressure over resistance, okay? Or ventricular volume equals is blood pressure over PR. PR is peripheral resistance, peripheral, the arms and legs, okay? Resistance, okay? We'll get into Darcy's equation a little bit more later when we talk about vasodilation and different things. But this is the equation that they figure out. Everything has sort of a math equation to it. Okay, in firefighting, there's a mathematical equation for the water running through the hose. Okay. In the amount of pressure that comes out of the hose. They do some math and determine how much water, because we lose water, we lose friction loss, right? And that really is a lot like blood pressure. Okay, so we do use a little math here in the physiology, but I hate algebra, so we're not going to really spend a lot of time there. Okay. Because we need to get more into the medical part of this, I think, and be caught up in this. Okay? So just remember this is Darcy's equation right through here, is going to help us figure out how to increase ventricular volume. Okay? We have to either increase pressure or decrease peripheral vascular resistance. Okay. Peripheral vascular resistance is the resistance of the blood flow in the arms and legs. Anyway, so we determined this. Now back to the more medicine part, because hypoxia. What's hypoxia?
No oxygen.
To the cells. Right? So to the tissue or into the cells. Hypoxemia is low oxygen to the blood. Good. Okay. So one thing that hypoxia causes is vasodilation. Hypoxia causes vasodilation. Vasodilation causes what?
Decrease in blood pressure.
Decrease in pressure. If we have a decrease in pressure, we're going to have a decrease in what?
In volume.
Volume, yeah. But initially, we got to put another piece of the puzzle right there. So we have hypoxia that causes vasodilation. Vasodilation causes a decrease in pressure. Decrease in pressure causes a decrease in what?
Cardiac output.
You have to have pressure to push the blood through the vessel, right?
Uh-huh.
That's called the MAP. In review, mean arterial pressure, correct? Y'all remember that from days gone by? Mean arterial pressure. The average mean arterial pressure, I believe, is 60 to 80. They'll quote me on the numbers, but that's off the cuff. Okay, so mean arterial pressure, the mean arterial pressure is the pressure needed to push the blood through the vessel. Okay? So we have a problem. We have a hypoxia. Now we have vasodilation. You're right. In the end, that's going to cause a drop in pressure, possibly a drop in cardiac output. But according to Darcy's equation, what do we have a problem with? Now that we drop that pressure. Huh? Flow. Right, exactly. We have a problem with flow. So we have a problem with flow, not like Flo the lady on TV. No,
She's great.
yeah. Not like flow, that flow. But we have a problem with blood flow, which means we have a problem with our mean arterial pressure. See how everything sort of connects together? Okay? As we look at it. So, that's one reason. The other thing that is a major factor in this is called autoregulation. Again, we talked a little bit about autoregulation some time ago, okay? But that's, remember, I think I gave you the example of like if you have 2 bathrooms in your house and somebody turns on the shower and you want to, you're doing something, you're watering the grass or something, somebody turns on the shower, someone's going to be without a little bit of pressure problem, right? They're going to be without water. They may get water, but it's not as much.
Mm-hmm.
You know what I'm talking about?
Or changes temperature.
Yeah, depending on the hot water, right? So you have, if you turn on 2 faucets, one faucet's going to decrease in pressure unless you just have really good pressure, okay? And that's what the body does. If there's a portion of the body that needs more blood, we only have a certain amount, right?
Uh-huh.
So the body's going to shunt, is the term, it's going to shunt that blood away through the process of autoregulation. So the heart and the brain are greedy organs. They always get their blood flow. So if the heart needs more blood, then through the process of autoregulation, it's going to shunt different organs, okay? The gut is going to be one of the first organs that it shunts, okay? If you take blood flow away, this is review, but it's good review. If you take blood flow away from the gut, what symptom is going to show up?
Would there be a change in color, like the
No,
person?
the gut is, yeah, not quite that deep, but
Would it hurt? Would it be soft, hard?
let me just tell you, nausea.
Oh,
Yeah. Once you pull blood flow away from the gut, nausea. You're going to get nauseated. The patient's going to get nauseated. Okay? So that's one key factor that controls tissue perfusion. Okay? Perfusion is adequate perfusion, right? Is the body's ability to supply oxygen and nutrients to the cells, right? That's adequate perfusion of the cells. So one thing that controls that is autoregulation. The other thing to control it is this vena cava squeeze. Okay, the vena cavas are surrounded by muscle. Okay, in this hypoxia, just not hypoxia, but hypoxia, a decrease in pH. So if we have a decrease in pH, what is the condition? Yeah, acidosis, right? So acidosis, or a powerful sympathetic response where we get a fight or flight response. Okay, so it's going to shunt different blood flow away, because the need is going to be more, right? In these cases, we need more blood flow. So what's going to happen is it's going to trigger the sympathetic response. It's going to trigger these muscles around the vena cava to contract. And they contract and it squeezes the vena cavas, which is going to create more blood flow, right? It's going to create more ventricular volume. Is that, everybody good with that? See how that sort of works out? So in these different types of responses, so we've looked at here. We've looked at how do we create more ventricular volume. That's what all this was about. Okay. The other one is how do we reduce residual volume, and we reduce residual volume by increasing ejection fraction. How do we increase ejection fraction?
Yeah, you
Very-
increase contractility.
Very good. Increase contractility. How do we do that?
More calcium.
More calcium, yeah. More calcium. More myosin heads, yeah. Welcome to physiology, right? Usually we do this by pharmacology. That person that needs more ejection fraction, like in that CHF patient, we give them medicine to increase contractility, okay? Until we can figure out what's wrong with the heart. We give them some medicine to increase contractility. This is that inotropic agent. I know, right? I have an O there. Is that right?
Yeah.
Inotropic increases the amount of contractility, increases the force. So you have a positive inotropic drug, like dobutamine. I'm just throwing out these names, I'm name dropping, okay? Not a big deal for it because we don't really get into that, but if you hear that name, dobutamine is an IV drip that they will give, medicine that they will give to increase contractility. So that CHF patient, the patient that we need to increase their ejection fraction, we'll give a positive inotropic drug. To send this patient home, they may give them start them on digoxin or dig. Okay, it's an inotropic drug. It's going to increase contractility. Just a FYI sort of trivial thing, not trivial. I can't say that because it's really important. Dig. It's measured. The dose is measured in point something.
Oh, dang.
You give too much dig, and you're going to see this crazy cardiac rhythm. That's how you can tell. Besides blood, drawing labs and checking their dig level, somebody with a dig overdose is just going to have this just crazy, irregular, weird cardiac rhythm. You can't interpret it because it's all over the place. That's one of the problems that they're going to have.
The person can die from that.
Oh yeah, quickly.
That's good.
So that sort of takes care of these determinants or determined cardiac output. The other thing that it gets into here is when it starts talking about these actin and myosin heads in CHF, and we've really talked about this. Oh, I should have flipped the sides. The vena cava squeeze, these muscles here, hypoxia, pH, fight or flight. Okay. So the thing with this is when I'll give you a second to jot that down if you want. But in CHF, we talked about this back when we introduced congestive heart failure to you, about the Frank Starling and the rubber band. Remember that? You know, ba-boom, 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 right? Normal contraction. And Frank Starling, his rubber band law said that you can stretch this rubber band normally, and it's always going to come back to the original point, okay? Right, and exactly. Till it loses the elasticity, till you overstretch it. When you overstretch it,
It won't come back to its
okay,
own motion.
it's not going to come this. So if you boom, 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 well, that's a tachycardia. Let me slow down. Boom, 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 right, boom, boom. So if you overstretch it, right, through failure,
It's not going to go back.
it's not going to go back. So it's not going to have the squeeze, or it's not going to have the contraction needed, okay? And that's where we sort of left that alone, right? We said, okay, leave it alone. We'll talk about it more during cardiac physiology. Well, that's where we're at. Because what happens is we go back to this, and what I want you to remember about it is this point here, where we go back to these actin and myosin heads, okay? And this inotropic part is, as everything has to be timed. Everything is timing, right? When you ask somebody out for a day, it's all about timing. Right time, right place, right? Body's the same way. It wants the right time, right place, right circumstance, okay? Homeostasis, correct? So what takes place here is this stretching that we're talking about, and this engagement of these actin and myosin heads. You get the maximum contraction when there's the correct stretch of the muscle. Okay? You get an improper what's the term I could use? Where it's improper length or stretch when with the actin and myosin heads, when it's too short or too long. So it has to be just right, correct? Boom. To get the proper contraction, to engage the proper amount of actin and myosin heads. If it's too long, it's not going to engage the proper myosin heads, and if it's too short, it's not going to engage the proper amount of myosin heads, okay? And so that's part of Frank Starling's curve or law. We don't need to get into that, okay? I'll leave that for when you guys are going into medicine. You're going to be doctors. You're talking all about this, okay? Enjoy it, okay? But when you get down to where we're trying to get through too quickly, when you get down to it, it's all about, am I getting proper contraction of the heart to get proper cardiac output, to get proper oxygenation to the tissues, right, in the cells? So sometimes that doesn't work out. When you have that patient with that poor cardiac output, you're probably not going to sit there and going, oh yeah, what about that Frank Starling's law? Their heart's overstretched. Their myosin heads are not acting. They're not engaging with the actin. If you do that, somebody needs to slap you.
Patient will die.
Yeah. I mean, you have to sort of think that way, in a sense. But you're thinking, hey, they're not getting cardiac output. What is the ejection fraction? You know, is their heart contracting the way it needs to? You can measure that. You can measure through waveforms this cardiac output. You can measure cardiac output. They can do an echocardiogram. Have you guys seen that in the hospital yet?
Yes.
Yeah, have you? It's
you
in
can
color.
see.
It's really cool where they're doing they have this thing that looks like a sonogram, but they go do it around the heart, yeah. And they see the ejection, they measure ejection fraction and everything through it. So these guys will come in and do this. I think they're called stenographers.
Sonographers?
Yeah. Huh?
Sonographers.
Sonographers, right? They do the echoes, and they measure all this, and then the cardiologist gets together and looks at it and goes, yeah, they have a poor ejection fraction. Okay? What do we need to do? They may have a calcium problem. Okay? But what do we need to do here? And that's sort of the point with the Frank Starlings law. I don't want you to get too involved in that. I just want you to remember that because of this Frank Starlings curve, okay, it has to be just right. These actin and myosin heads have to combine. It has to have the proper stretch. Okay, if it's too short or too long, the myosin heads won't engage the actin properly, and you're not going to get the contraction that you need. Good? Okay. Then this is sort of what we've spoke of, the regulation of heart rhythm. You have these different terms that I want you to write down. Can you read this? Anergic? Adrenergic. Okay. What that means is that means when you hear an adrenergic response, it's sympathetic. It's a sympathetic response. Okay, it's working with norepinephrine or an epinephrine-like substance. Okay, usually norepinephrine. Okay, to create a chronotropic effect. Okay, chrono means time, so fast. Chronotropic, a faster heart rate, right? This would be slower because these are further apart, correct? So we know that in EKG interpretation. The further apart the QRS complexes, the slower the heart rate, right? The closer they are together, the faster the heart rate. Anyway, we talked about inotropic, that's the fast. The force of contraction. Dronotropic is to increase it through the time through the AV node.
Dromo or promo?
Dromo. It looks like a P, doesn't it? But it's dromo. Dromotropic. Increase the rate through the AV node. Chronotropic is to increase rate. Inotropic is to increase force of contraction. So we regulate this sympathetic response for this heart rate. Regulate
Depends what's up.
Okay. We're almost done. Give me a couple more minutes. I want to write down some terms just so you know have the words here. They're so long it'll take me a second to write it down. Because in medicine, why do they have 2 or 3 names? It's like the highways. Why do they have 2 or 3 names for highways? Why can't they just call it one name? Right?
I don't know, because there's dumber,
Yeah.
and dumbest.
Okay, so you have acetylcholine, or you have the same word, cholinergic, which means slow. So if you have acetylcholine and this is abbreviated, these are all uppercase, ACH, so the acetylcholine, this is, or cholinergic, this is a response that's going to affect the vagus nerve. You have cranial nerves, okay? But we've talked about the vagus nerve before, right?
Yeah. It's in the neck, isn't it?
Slow response. It slows the heart. Activation of the vagus nerve will slow the heart rate down. Okay. Suctioning will do this, potentially. you over-suction the patient, they might get a vagal response, which is going to slow the heart rate down. Okay, and so it's through the cranial nerve system, but it uses these acetylcholine or this cholinergic mediators to do that. Just to complicate things a little bit. Do y'all hear that? Or is it me? Okay. Okay.
Oh my god. Oh, negative.
Okay, so these are receptors. Right? So you have the little receptor there. These cells are like have all these antennas. You can just picture all these antennas on top of these cells, and they all have different receptors in this. I don't really need, you can write this down, but I just want you to, this for sure. But this one is in the heart. It's also in the brain and muscle cells as well. But it brings the heart rate back to normal. So this one's going to decrease this sympathetic response. Okay, it helps. This is the receptor that. So this acetylcholine with this cholinergic response is going to combine with this receptor to bring the heart rate back down. Okay, so these are receptors. This is a chemical, in a sense, a chemical mediator. Okay, and so this acetylcholine is going to combine with this receptor to bring the heart rate back down. It's going to affect the SA node. It's going to bring it back down. This one is found in skeletal muscle, just different receptors, okay? And then this one's found in bronchioles. The reason I bring all these up,
wait, which one's
this is a 3.
Okay.
So this one's in bronchioles. The only reason I bring this up is not to confuse you, but to I want you to at least keep it in mind that you have the chemicals, right? You have norepinephrine, epinephrine, called acetylcholine esterase. Okay, so you have all these different chemicals in there that affect the heart, affect the bronchioles, but then combined with these, you have receptors. Okay, what other receptor sites do you guys know about?
In your heart, the one in the aorta, the one you have in your necks, like the one in your aorta.
Yeah, your aortic body. Those chemoreceptors, right? They're very good. You get the chemoreceptors that are going to measure levels of what? CO2. You breathe off the level, pick that up. So yeah, we have receptors. It's going to do what? Lungs, right?
Yeah, they.
Receptors.
Does the opposite.
Very good. Yeah. So you have not that you have to. That's somewhere. Okay, I don't know, but you'll go back. You'll hear this again later in your life, and it definitely do it. It's just a matter of Kim, maybe, you know. Hey, what's up? Yeah. Anyhow, I wanted to throw that out in case not to leave you hanging on that. Okay. Questions? Everybody good? Ready for a break? Okay.